Good evening, everyone. I'm Robin Toohey, Senior Director Support Groups of the International Myeloma Foundation, and it's my pleasure to welcome you to tonight's teleconference, The Importance of Bone Health and Treatment Updates. I'd like to thank our sponsors for their support of tonight's call, Amgen Oncology, Celgene, and Takeda Oncology. Tonight's program is part of the IMF's Living Well with Myeloma series, which is designed to cover all the important and most up-to-date information regarding myeloma to help you live well. This evening, we're very pleased to have join us Dr. Noopur Raje and Dr. Beth Faiman. Dr. Raje is an Associate Professor of Medicine at Harvard Medical School and is the Director of the Center for Multiple Myeloma at Massachusetts General Hospital Cancer Center. She is a translational researcher with a primary research focus on understanding the biology of myeloma and developing novel therapeutic strategies for the treatment of myeloma. She's specifically interested in bone biology with a focus on the microenvironment and strategies to manipulate this niche. Dr. Raje trained in internal medicine at Massachusetts General Hospital and completed a fellowship in hematology and medical oncology at the Dana-Farber Cancer Institute in Boston. Dr. Faiman received a Bachelor of Science degree in nursing and registered nurse certification, Master of Science in Nursing and certification as an adult nurse practitioner, and a PhD in clinical research and nursing. Dr. Faiman holds an advanced oncology nurse certification and is currently employed as an adult nurse practitioner in the hematologic oncology department at Cleveland Clinic. Dr. Faiman is an active author, presenter, and educator on myeloma, is part of the IMF's Nurse Leadership Board, and is currently editor-in-chief of the Oncology Nurse and on the editorial board of ASH Clinical News, among many other notable books and articles relating to diagnosis and management of myeloma, pain, palliation, and cancer symptom management. It is now my pleasure to turn this call over to Drs. Raje and Faiman. Dr. Faiman, would you begin, please?
Thank you. Thank you, Robin. Thank you, Dr. Raje, and thanks to everybody who called in today. What we'll be going through these slides, I will be highlighting the title of each slide and what the key points of each slide are. I'll begin with a short overview of bone disease, and then Dr. Raje will present some clinical studies to highlight the importance of bone health in patients with multiple myeloma. But first, I wanted to direct you to the International Myeloma Foundation. This next slide, slide number 3, does highlight the new logo and the different portions of the International Myeloma Foundation. So we have the International Myeloma Working Group, the Nurse Leadership Board, and various other projects that are currently available. And if you'd like to learn more about the different facets of the IMF and the different areas, please go to www.myeloma.org, and you can highlight on the icons to learn more about these important areas. So let's begin with an overview of myeloma and bone disease. So the next slide is kind of a cartoon slide, and it shows all the different effects on the major body system. Most of you who are on this call are very aware that multiple myeloma can involve the blood, causing anemia, challenges with blood clotting, low immune cells, and that can lead to tiredness, dizziness, and headache, among other things. The multiple myeloma cells can affect one's kidneys, leading to protein in the kidney, abnormal protein formation called amyloidosis, which isn't part of everybody's diagnosis, but it's something we look for, high calcium, and kidney problems. Now, this kidney area is something we're going to talk about a little bit more as it relates to treatment of bone disease. And then obviously, part of the CRAB criteria for diagnosis includes the bones, where lytic lesions, thinning of bones, high calcium in the blood can occur. Dr. Raje and I have the good fortune to be managing myeloma for many, many years, and we've really seen an evolution on patients and their bone health, and this is something that we're going to be discussing this evening. On the next slide, most of you are very well aware of the test to diagnose multiple myeloma. This is a combination of blood tests, bone marrow biopsy, and of course skeletal imaging to really identify whether or not an individual with multiple myeloma has damage to one's bones. You can see to the bottom of this slide, number 6, a few different pictures of what the bones look like when they've been invaded by myeloma cells. And you can imagine this weakened bone structure will place people at an increased risk for fractures, which can be devastating. And think about how much pain that could occur. Now the next slide highlights all of the good news that we have with the longer treatment options. To the far left of this next slide, which is a timeline slide, 1958 melphalan and 1962 prednisone, which it's interesting to me because we just had an FDA approval of a drug combination which includes melphalan and prednisone for newly diagnosed multiple myeloma. So while we are using older therapies, fast forward to the 2000s and all of the numerous therapies that are currently available. So patients are living longer with longer life expectancy, so we really want to protect one's bones so that they can live well for a longer period of time. The next slide highlights some of the challenges that we do have with treatment of myeloma. So we know multiple myeloma produces clones, and these clones change over time. So while it's important to find the right treatment that works best for you, balancing what is important to you, what's important to managing the myeloma, it's important to keep an eye on the blood test as well as what's occurring in the bone environment. Now the next slide is a common slide that you're going to see throughout this presentation, little variations on this slide. Slide number 9, talking about bone turnover in myeloma. So we all have these cells called osteoclasts. The job for osteoclasts, and that looks like the little scrubbing bubbles guy on the left-hand side of the slide, the osteoclasts are responsible for bone breakdown. On the other hand, you have the little guys that are called osteoblasts, and their job is to cause healthy bone formation. What happens in myeloma is there's an imbalance of the bone breakdown without bone rebuilding. Therefore, Dr. Raje is going to discuss in a few moments the different treatments that we have to eradicate or protect you against this bone breakdown process. The next slide is a little bit of a complicated slide, but I like it because it really highlights these osteoclasts. Again, that's in the middle of the slide. That's titled Immune Basis for Myeloma Bone Damage. Again, this osteoclast, their job is normally to break down bone and rebuild it. So where I had a more basic slide previous, you can see all the chemicals and the what we call cytokines that are in the bone marrow environment that really interrupt this process. So there's a two-way, what I call interaction between the bone marrow cells and the bone marrow microenvironment and the tumor cells. So the chemicals will further dissolve bone without rebuilding. That brings us to slide 11. I like this cartoony slide because this is really an analogy of what bone disease and myeloma is like. It's a structural demolition which is fueled by these cytokines. So these last slide had some letters and numbers, this DKK1 and MIP1A and all these different things. And again, these chemicals will fuel the bone breakdown. So whereas we think of we want to build bone in myeloma, it's really under destruction. Now the good thing is with effective treatment in multiple myeloma, you can really squash some of this activity. And then if we bring in bone drugs to rebuild bone, like Dr. Raje is going to go over in a few minutes, then we can hopefully rebuild some of that or at least stop the process. The next slide, it's titled Bone Disease in Multiple Myeloma, talks about what the impact is to the person. Dr. Raje has done a lot of work in bone in the lab and in the clinic, and she can speak firsthand to this. But in the olden days, I call it, in the 1990s, people would walk into my clinic and they'd be all hunched over because multiple myeloma likes to affect the spine, the head, and the long bones, and you would have this weakened bone structure from these vertebral compression fractures. And now with effective treatment, we can stop that and the rebuilding bone, but that still can occur. About 80% or more patients will have damage to one's bone. And again, this slide is highlighting that spinal fractures are one of the biggest problems. And think about what happens when your spine is collapsed. You can't take a deep breath, so you might be not getting good air to the bottom of your lungs, which puts you at risk for pneumonia. And you're also probably having some degree of pain, which leads you to not want to get up and walk around, so that you're at an increased risk for blood clots. So this can be a vicious cycle when one has spinal fractures in their back and fractures elsewhere. How do we diagnose bone problems? Well, the next slide talks about bone imaging methods. There's a lot of discussion as to what the best method is, and now currently we would love to order things such as PET scans and MRIs, but quite frankly, not all insurance companies will reimburse those tests. So the historical gold standard is the skeletal survey, which looks at head to toe, x-rays of your bones, looks for damage, but you have to have about 30% bone loss before you can see damage to one's bone. So the newer bone imaging methods are now what is trying to be recommended, and we'll talk about that a little bit more. But at this time, I'd like to turn the microphone over to Dr. Raje, who's going to share with us some updates in bone disease treatment in myeloma. Dr. Raje?
Yeah, thank you so much, Beth, and thank you all for joining this evening and spending time with us. Beth has done a phenomenal job going over the biology of bone disease, and I think it's really important to understand and appreciate why you get bone disease so that you have a better understanding of how you can better address this problem. So obviously, along with the treatment for myeloma, we have come a long way with treatment for bone disease as well. And as Beth so rightly pointed out, what we used to see in the 70s and 80s, we don't see that often anymore. But the one thing I do want to highlight is the fact that with all of those wonderful treatments where you saw that nice bar chart, everybody with multiple myeloma is living a lot longer. So you are at a higher risk of bone-related problems over time, and that time is now in years, 10, 15, and even longer. So that is a good news problem, but it underscores the importance of us trying to address bone disease in patients. So I'm on slide 15 right now, and the biggest things to appreciate and understand is for the treatment of bone disease, most of us are using bisphosphonates, and we'll go into the different types of bisphosphonates in a little bit. There's a newer agent, which is a monoclonal antibody, which I will touch on as well, denosumab, and I'll show you some data with that. We do use adjunctive procedures, and specifically surgical procedures. As Beth just pointed out quite nicely, is you do get vertebral fractures, and in fact, majority of bone disease occurs in the axial skeleton. You end up with vertebral compression fractures, and there are things which we can do, like a vertebroplasty or a kyphoplasty in specific situations, which can actually help relieve pain quite significantly. We do tend to use radiation sometimes. I will say that radiation should be used less frequently, and in specific situations, we do not want to be using too much of radiation because radiation can, in fact, impact your blood counts, and we do not want to be doing anything to compromise your actual therapy for multiple myeloma. I think by far the most important thing for even the treatment of bone disease is treating the underlying multiple myeloma is going to make your bones stronger and better as well. Obviously, when you think about treatment for myeloma, and I'm on slide 16 now, there are certain issues that we do deal with. And again, I look at these issues as more good news problems because these issues have arisen because we have been using these bone-targeted agents now for years and years and years. And with that, we've come across the problem of osteonecrosis of the jaw, which is seen on this slide here where you see a bridge has been placed and there's a site of tooth extraction. And right under the bridge, what you can see is a little bit of exposed bone there. and that essentially is osteonecrosis of the jaw. And why the jaw? It tends to be the jaw because the bone in the jaw is closest to the skin surface, closest to the mucosa. Anytime you disrupt that, you will end up finding problems with bone metabolism, because we're really attacking those osteoclasts, which Beth talked about, pretty aggressively with drugs like zoledronic acid, as well as the newer ones now called denosumab. There are other problems also that we see, and the one thing which has been noted in patients with multiple myeloma, I will say that these are fairly rare. It happens in about, the ONJ happens in about 3 out of every 100 people, and the stress fractures is even less. But nonetheless, you can get fractures in my bone which are unrelated to myeloma, and that's because of disrupting bone metabolism in patients with multiple myeloma. We talked about the use of bisphosphonates in the treatment of myeloma, and the question really is, do any of these bone-targeted agents actually have anti-myeloma effects as well? Now, that has been shown in some studies, and there are subsets of phase 3 studies also which show that if you treat the underlying bone disease, you are going to see a benefit in terms of myeloma outcomes as well. People live longer if you control bone disease better. And this was highlighted quite nicely in the MRC9 trial, and we'll go over that some. The Nordic study also showed that, and more recently, when we've done the large denosumab versus zoledronic acid, certainly we've seen a benefit in terms of disease control as demonstrated by a progression-free survival benefit in these patients. So going back to some of the old studies and to try and tell you why we use what we use for the treatment of myeloma-related bone disease, most of you who have myeloma probably are on one of two drugs. It's either zoledronic acid or the other drug called pomegranate. Both of these are given intravenously, and when we've done studies, now this is way back in the late 1990s, when we compared these two drugs, what we found was pomegranate was just as good as zoledronic acid in terms of controlling myeloma-related bone disease. So either one or the other is perfectly reasonable to use, and up until recently, our recommendation was to use either one or the other. People who had kidney-related problems, we tended to use pomegranate compared to zoledronic acid. Both of these drugs are given intravenously, and most of you are familiar. If you are on pomegranate, or the other name for it is Iridia, you generally get it over 3 hours or so. If you're on zoledronic acid, we recommend that you should get it at least over 30 minutes. There are practices that do 15 minutes. I generally prefer 30 to 45 minutes, specifically in patients with myeloma, because we do worry about kidneys in folks with multiple myeloma. So what about the MRC9 trial? And this is kind of highlighting the fact that zoledronic acid, in this study, there was close to 2,000 patients. I'm on slide 20 now. And what was done by the UK group here was half these patients were treated with zoledronic acid or Zometa, as you all are familiar with. And in the UK, they also had an oral drug called clodronate, which was approved for the treatment of myeloma-related bone disease. So half the patients ended up getting clodronate. What they were very nicely able to show in this MRC9 trial was that zoledronic acid significantly reduced the incidence of bone-related problems in patients with multiple myeloma. But what was most important, I think, and this needs to be underscored and appreciated, if you look to the right of this slide, now being slide 21, what you are going to see here is whether you had bone lesions or no bone lesions to begin with, zoledronic acid was still able to protect you from future bone-related problems. And therefore, I think the take-home point from this is it doesn't matter whether you have cell-related problems. It doesn't matter whether you have lytic lesions on your x-rays or whatever other imaging modality has been tested or used in you. most patients should be getting a bone-targeted agent. It could be zoledronic acid. It could be permitinate, and more recently now we could even consider using denosumab, which is approved as well. Moving on to some of what we are doing in terms of understanding how some of these drugs work, what we did was a study here, and this was essentially to answer the question of, how can we prevent some of those long-term complications that I talked about? One of them being the osteonecrosis of the jaw, the other one being the stress fractures which were seen. And to do this, what we looked at is blood and urine biomarkers in patients, and we looked to see if we were really causing a lot of problems with bone metabolism by over-treating patients with some of these drugs. So we essentially looked at a marker called urinary N-telopeptide. This is a bone biomarker. And if you look at this, the majority of patients had low bone biomarkers, suggesting that some of these drugs really do impact bone metabolism. And it may, in fact, be a good idea for us to, rather than give you once a month, every month, either the bisphosphonate or the denosumab, can we think about treating you less frequently? And if we did that, would we still have that bone protective effect on you? So to try and address this again, we went from the lab back to the clinic, and what we did here was the ZMARK trial, which is illustrated on slide number 23. And this was a biomarker-directed strategy so that most patients got, depending on their N-telopeptide levels, got zoledronic acid or Zometa given every 3 months. There were very few patients who had high N-telopeptide levels who ended up getting it monthly. But the bottom line here was the fact that this ZMARK trial for the first time demonstrated that you can do with less therapy, so giving less frequent dosing of zoledronic acid is perfectly reasonable. When we looked at long-term complications here, we certainly didn't see any stress fractures, and the incidence of osteonecrosis of the jaw was quite low in patients, of about 2.6% or so. It was still there, but it was still certainly better than what it was before. So in general, after your myeloma is under good control, one can certainly think about backing away from how frequently you need to be on the bone-targeted agent, and you can talk to your doctor or your team and try and cut it back to every 3 months or so. What about some of the other newer agents? Well, we've been talking about denosumab. This is demonstrated now on slide 25 in a cartoon form. It's very different from Zometa or zoledronic acid because this is actually a monoclonal antibody. And what this monoclonal antibody does is targets a protein called rank ligand. Now, rank ligand is a protein which is produced by your stromal cells or the cells which surround your myeloma cells. And what rank ligand does is activates those bad cells or the osteoclasts, which are your bone-destroying cells. What denosumab does is it targets rank ligand, it neutralizes rank ligand, and therefore prevents these osteoclasts from multiplying and causing bone destruction. So a monoclonal antibody, very different from zoledronic acid, and we've always shown in patients with multiple myeloma that a lot of you will have high levels of rank ligand, suggesting that this monoclonal antibody may in fact be a good target. So we went ahead and did a very large study. This is more than 1,700 patients, wherein half the patients, everybody got their anti-myeloma therapy, but half the patients got denosumab, and the other half of the patients got zoledronic acid, which has been accepted as the standard treatment for taking care of bone disease. Now, difference between denosumab and zoledronic acid is zoledronic acid, as you all know, Zometa is given intravenously over at least 15 minutes, more should be more like 30 minutes to 45 minutes. Denosumab, on the other hand, is a subcutaneous shot which is given under the skin, so a lot easier. when we looked at the data in patients, what we found was that both zoledronic acid and denosumab worked just as well in terms of time to developing any skeletal-related problems. There was no difference in terms of survival in patients, and that just may be a reflection of this being done early. And if you go to slide 28 and look at the progression-free survival, and going back to the question of whether some of these ancillary therapies for multiple myeloma will in fact have an impact on the disease itself. Now, this was very clearly demonstrated in the denosumab zoledronic acid trial, where patients who got denosumab actually had a very significant improvement in their disease control of close to 10.5 months. So again, very impressive difference in disease control when we're using a bone targeted agent. So I'm going to turn this over again to Beth, where she's going to talk a little bit about how we help with some of the supportive care strategies for some of the complications that you see. And towards the end, I'm sure both of us will be happy to address and answer some of your questions. So over back to you, Beth.
Thank you, Dr. Raje, for that wonderful overview. I think this is one of the biggest questions in managing myeloma in 2018 is what drugs to give and when to treat the disease. And now that we have 3 excellent drugs, such as the zoledronic acid, pamidronate, and denosumab, how do we use these medicines? She demonstrated that in that zoledronic acid versus clodronate, which are pills, that MRC9 study earlier on, that helped people stay in remission longer. And now we have this denosumab, which could potentially keep patients in remission longer. So those are important questions that I'm sure through research will be answered. I do want to go to the last 2 slides before we have a little bit of discussion and open up to questions. So the slide I have is titled Bone Health and Supportive Care, and I believe it's about slide 29. I think I have the same numbering of the deck. But at the end of the day, there are some updated recommendations, and I believe Dr. Raje was one of the authors in this publication of the Journal of Clinical Oncology that bone strengthening agents are recommended for all patients receiving anti-myeloma therapy. That is a little bit of a change because while we've been saying in some of the guidelines from the International Myeloma Working Group and other organizations such as National Comprehensive Cancer Network, there's numerous organizations that make recommendations, but again, we're trying to personalize therapy for most people with myeloma. And yes, you can take it for 2 years, but again, we need to do more research. Dr. Raje is suggesting by checking a urine level of that NTX or that N-tillopeptide, maybe we can personalize it for some people who have good remission status. But the take-home point is to just keep in mind how important bones are. So again, it can be any one of those 3 medicines, pamidronate, zoledronic acid, or denosumab. As patients, it's very important to remember good dental health monitoring. Although, as Dr. Raje mentioned, that incidence of osteonecrosis of the jaw, and her picture is up on this slide as well, too, with the exposed bone underneath that backbone, that back tooth. That's an extremely rare complication, but we still do see this in 2018. So going to the dentist, regular x-rays, and keeping your teeth clean. One of the big questions is dental procedures, and I'll ask Dr. Raje how she addresses this in a moment, but there's the big question about dental procedures. Can you safely have dental cleaning? In general, if it's not a lot of irritation to the gum line, I generally say it's okay, but if there's more root canals, that's still probably okay, but we try to avoid tooth extractions for the reason that many people will not heal as well unless it needs to be done. That's why we always try to get a good baseline dental exam if we have the time before we start these medicines and really take care of all the dental issues ahead of time if we can. I put on this slide the importance of kidney health monitoring. Over time, if one stays on these drugs, it can cause what we call tubular damage. So when we're looking at your 24-hour urines to see how your myeloma is doing for most of you, we can look to see if there's more of this albumin in your urine to make sure that your kidneys are still functioning normally. It's also important if you're on these medicines to have regular serum creatinine tests. The creatinine is the blood test that tells us how well your kidneys are functioning. There's one also called GFR, but most of you are aware of this creatinine level. So we will sometimes adjust the doses or adjust the type of medicine you're on based on your kidney function. And of course, Dr. Raje mentioned the role of some minimally invasive surgeries, and sometimes they're more invasive. So if you do have myeloma that's not well controlled or you've had a compression, this balloon kyphoplasty is a minimally invasive, generally outpatient technique where you would go into the operating room or an interventional radiology center. The pedicle is the little ears behind the vertebral body, so the surgeon or the interventionalist would put in a balloon to raise up those vertebral bodies. The balloon is deflated, and in its place is dental cement. Well, I say dental cement, but it's called polymethyl methacrylate is most commonly used. It's kind of the equivalent of Dairy Queen Soft Whip. I like Dairy Queen ice cream. I'm not plugging for Dairy Queen at all, but that's a common, soft serve ice cream. And then it hardens immediately. And so the goal is to try to fix that fracture like you'd have an external cast. It's an internal cast. As Dr. Raje mentioned, years ago, before we had effective therapies, we used a lot more radiation, but now it's important to try to minimize radiation only if you have some very painful sites or soft tissue masses, and that would be in discussion with your surgeons and your doctors and your radiation oncologists. And then finally, report new pain to your healthcare providers. It's very important to speak up. If you're not on bone treatments, ask your doctor. It's okay to not be on them, but it's also important to know why. The last slide, which is slide number 30, talks about the key points in preventing bone complications and exercise. Again, we don't want you to do a triathlon, but walking 5 to 10 minutes most days, lightweight bearing, it's all very good for your bones to rebuild cancellous bone. For those of you who are on bisphosphonates or specifically this denosumab, it's important to make sure whether or not, discuss this with your healthcare provider, you should be taking calcium and vitamin D. We've seen very, very low levels of calcium on these very effective bone drugs. So talk with your provider about the right doses for you and whether or not you should be taking it. And then finally, we should be watching with regular monitoring of your bone disease. This is between you and your treatment team, what kind of imaging and how often, but it's important to have that discussion as to what to expect. The next slide and the last slide before we go to questions highlights the important resources that are available to you. The International Myeloma Foundation has put lots of effort towards putting information out, and it's all free. So go to myeloma.org, and you can request any of these to be sent to you. You can call the info line, which is 1-800-452-CURE, and you can get a live person Monday through Friday, 9 a.m. to 4 p.m. Pacific Standard Time. And then finally, sign up for the e-newsletter and the Myeloma Minute to stay up to date on the latest treatments. I want to again thank you for your kind participation. I'm going to turn it over to questions, but I wanted to just ask Dr. Raje, do you use the urine NTX in your clinical practice currently based on the good results of the DMARC study so far? Because back in the early 2000s, we started doing that temporarily at my institution, and then we kind of stopped because it seemed like everybody's levels were low. Can you speak to your practical experience on that?
Right. So, that's a really great question, Beth, and most of us do not use that. So we did try and do it in the ZMARC study, but as I showed you, even in the ZMARC study, we treated 121 patients. Most of them had N-kilopeptide levels which were below 50, and therefore you don't really need to do it. And we found that in most of those patients, we were safely able to give the zoledronic acid every 3 months. So although that was a biomarker we used to design the study, in real clinical practice, I do not think you need to use any of these bone resorption markers. But I think the most important thing with that study was it was able to show us that bone resorption markers are significantly suppressed and you can actually get away by doing less frequent dosing. It certainly doesn't tell you that you have to be using that as a marker. You do not need it.
Great, thank you. And one more question for you before we open it up. So you mentioned about pamidronate being a little safer to the kidneys. There's dose reduction schedules with zoledronic acid, but many of the guidelines say if you don't have normal kidney levels, like the creatinine or GFR, we call it as well, then these drugs should be avoided. Now, denosumab, that's safe with kidneys, correct? Can you speak to the benefit with denosumab in kidney?
Yeah, well, that's a great point, and I was going to bring that up if you hadn't brought it up already, Beth, but thank you for doing that. So, up until recently, we did not have an alternative, and therefore we really looked at the GFR closely. We dose-reduced the zoledronic acid, and in patients with renal failure, we ended up using pamidronate, which is a little less toxic. Having said all of that, with the data with denosumab, given that it's a monoclonal antibody, it is actually not cleared by your kidneys. So it doesn't matter what your kidney function is. You can get denosumab anytime. And when we've looked at that very large trial, we have not seen it. It actually had a renal protective effect, so it was not toxic to the kidney. There was no further reduction in your GFR or your kidney function when you were on denosumab. The one word of caution, though, I think one has to remember is, as you had mentioned earlier on, when you're on these bone-targeted agents, it's important to be on supplemental medications. So calcium and vitamin D is really very important. And in folks who have a little bit of kidney dysfunction, and if you get drugs like denosumab, the chances of you becoming more calcium deficient are higher, and you really need to keep up on the calcium supplementation as well as the vitamin D supplementation.
Excellent. I think at this point we can open it up to questions.
Yes, hi. Thank you for the wonderful webinar here. It was very, very informative. I'm a myeloma patient. My question is, how long do we need to stay on the Zometa? I am on Q3 months Zometa infusion now, but how long do we need to stay on that for the bone health? For how many more years? Or is it a lifetime infusion, or do we take a break from it? Thank you.
Gosh. Dr. Raje, do you want to address this?
Sure. So, that's a really excellent question. And the bad news here is we don't have good data to give you good recommendations. What I am going to say in clinical practice, you should be on a bone-targeted agent pretty much forever because your risk of bone disease does not go away with time. And you're still at a risk of developing bone-related complications. I like that you're on every 3 months of the zoledronic acid, and over time, if your disease is in remission, that's a discussion to have with your doctor, and even consider being on it less frequently so that you're not prone to any of those complications that we talked about. The other thing I will mention here as well, because this is really important, so a drug like zoledronic acid, if for whatever reason your oncologist decides to stop, it's still okay because drugs like zoledronic acid and pamidronate stay in your bones forever. But if you were on a medication like denosumab, that should not be stopped without giving you something else instead. Because remember, denosumab is a monoclonal antibody. It's a reversible monoclonal antibody, and it doesn't stay in your system forever. So that as soon as you stop it, there is a very good chance that the bone disease can get activated even more. But in general, in my practice, I keep my patients on bone-targeted agents pretty much forever.
Yeah, and this is, I just wanted to say another 2 cents to add. That was an excellent response, Dr. Raje. I agree that patients should be on it, but again, taking into consideration your remission status. If you are in the most excellent remission and you've been on bisphosphonates for 2 years and your bones are in generally good shape, again, we try to personalize treatment, and you might be the individual where we say, let's take a break and keep you on your maintenance for your myeloma. And as long as the myeloma is in good remission, you're less likely to have more bone destruction and breakdown. And so then we would restart the bisphosphonates if the disease progresses. So again, I think there's 100 different opinions on how to manage myeloma bone disease, but have that discussion with your team. Thank you.
Thank you.
Thank you so much for all the great information. My husband is newly diagnosed, so I guess the question is, do you consider doing these agents monthly in the beginning while you're first starting treatment and then go to an every 3 months? Is that what I'm hearing after in remission, or when is that decision actually made?
Yeah, we tend to go to monthly. All the data is with monthly treatment, and initially with initial diagnosis, treatment of the myeloma and using a bone-targeted monthly is the way the recommendation really is.
Okay. Yes. And my next question is only because we asked this question about Exgevia and Zometa, and the doctors at Sloan and at Dana-Farber are saying the opposite of what the study showed with the denosumab. They said Zometa had more of a anti-myeloma effect than the denosumab, but that's kind of not what I heard from you this evening.
Yeah, that's not what the data shows. The data shows that when denosumab was compared to zoledronic acid, denosumab seemed to have a better control.
Okay. Well, thank you very much. I appreciate your response.
You're welcome.
Thank you.
Thank you.
I'd like to know if I've already had 2 years worth of Zometa, and I haven't had Zometa in 2 years. It's about 2.5 years. So, but I have a lot of lesions. I'm in my 7th year. I have lesions all over the place. So it would be recommended to restart the Zometa?
Ooh, that's a tough question. So I'm going to take that quickly, and then I want to hear Dr. Raje's opinion. So if your disease, again, and I look at the imaging to take into the consideration the recommendation. What are the bones? And it sounds like your bone health isn't so great, but are these lesions stable? And so staying up on the imaging, calcium and vitamin D, weight-bearing exercises tolerated, not running a triathlon. But those are things that you can do without necessarily the guidance of your treatment team. Again, some physicians have very strong opinions that the recommendation is monthly for 2 years and then you can stop. Again, I don't like to recommend to stop, but again, if you're in excellent stable disease, and so have that discussion. Well, then I would have that discussion with your treating provider and find out why you would be taking them or not. Is it because of your kidneys or for other reasons?
Well, actually, I was told a couple of years ago that the half-life was huge. So 24 months was, at the time, a couple of years ago, which was recommended. I'm just saying that my lesion issue keeps marching on. And I have them from head to pelvis, and so I'm just wondering. I haven't done it in 2 years. I'm wondering, should I restart?
Well, you have to think and keep in mind why we're recommending this, to decrease the risk of skeletal-related events or fractures. And so your physician should weigh the risks and benefits of fractures with you and active myeloma and active myeloma as well. And yes, it does stay in your bones, so I would just ask your treatment team, be your own advocate, so why are you not recommending, if my myeloma is not in good control and I haven't had this for 2 years, have that discussion with them.
Okay.
Dr. Raje, do you have any points that you'd like to bring up?
I agree with you, Beth. So, as I pointed out earlier, your risk of, once you have bone disease, your risk of bone lesions is compounded. Part of the problem with this 2-year mark, there is no magic number at 2 years, right? And the reason why people follow the 2 years is the clinical trials went on for 2 years. That's not what practice is all about. So what my suggestion is going to be, and I agree with you completely, that the half-life of these drugs is very long. They stay in your system forever, but doesn't mean that just because they're in your system, they're working against newer lesions. The MRC9 trial, for example, if you're able to tolerate the zoledronic acid, you should be able to continue it. Because of the other issues of toxicities associated with these drugs, I generally would recommend backing off and giving it less frequently, but I still do think that you should be continued on therapy. This 2 years is kind of a false, it's just an endpoint based on the trials which have been reported. That's all.
Okay, thank you very much. That makes sense. Okay, thank you.
The next question comes from the line of Robert Coles. The line is open.
Good evening. Thanks for the information tonight. I was wondering, with regards to the lesions themselves, do they ever improve over time? Do they, with bone remodeling, will they ever, return to normal bone, or will these kind of bone scars always remain?
Dr. Raje?
Yeah, I'm happy to take that. That's a great question again. So when you have bone destruction and those actual lytic lesions, they don't heal completely. What we do see, though, while you're on treatment, your anti-myeloma therapy as well as these bone-targeted agents, is thickening of bone around these lesions, and that is oftentimes reported as osteosclerosis. And when you see that, that's a good thing. Having said that, I will tell you that we are working very hard in the lab, and we also have drugs in the clinic now where we are working on bone anabolic agents. So all that we've talked about this evening are anti-catabolic agents, so they prevent bone destruction. But in the future, stay tuned to, and you will be seeing clinical trials where we are using bone anabolic agents, and that means that this is going to cause bone formation, and our hope is that in the future we are actually going to see filling of those holes of those lytic lesions. We already have a clinical trial which is open, at least where I work at MGH. We have a trial with a drug called sotatercept, and this is a bone anabolic agent. It's the first one in the clinic now, and we've seen that with this drug we are seeing DEXA scans improve, and we're seeing PET scans improve. Obviously, we'll have to wait and see. And there are a bunch of other drugs in the pipeline as well, which we're working on in the lab. And the hope is that we are going to see bone healing in the future.
Hello?
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 Go ahead.
Yes, can you hear me? Okay.
Yes.
Yeah, the question I have, I was diagnosed in 2009 with multiple myeloma because I had tumors. I had treatment and all the whole 9-yard stuff. And then I had a relapse in 2016. And now they're treating me with I had 2 bone marrow transplants. The second one was in December of 2016. And now they're treating me with Ninlaro because I had some issues with Revlimid and the dexamethasone. And it's manageable right now. It's manageable. So my question is, when you take all this medication and go through all this radiation and so on, is there any heart health issues that could happen while we're going through our journey, our myeloma journey?
Yes, this is Beth, and again, everybody's. So I always like to say what Robin Toohey says: that your myeloma is your myeloma, and my myeloma is my myeloma. So when we recommend different drugs to treat the myeloma, we also take into account the different side effects that we've learned from clinical studies. So when you're started on a therapy, we know from those clinical studies what the risk of heart damage and nerve damage and others is. So your treatment team should keep up on the monitoring and ask you questions like, are you having shortness of breath or chest pain, and keep up to date on your health maintenance, get your cholesterol checked, because people are living so much longer than you were in the past. So we can minimize your risk factors for heart by staying active and eating a good diet and keeping up on your health maintenance. So yes, there is always a risk with any treatment for heart and nerve and this and that, But again, we would try to personalize our recommendations to you and try the best that we can to get EKGs and echocardiograms and appropriate lab testing and do what we can to minimize that risk.
Wonderful, because that's wonderful, and that's exactly what I'm on top of. I am very proactive in this, and I was shocked when I found out I had this type of disease. But thank God for research. Thank you.
Well, continue to be your own advocate, and if you ever have any questions, don't hesitate to speak up to your healthcare team.
Hi, thank you. I have smoldering multiple myeloma, and part of that diagnosis is osteopenia. So a year and a half ago, I had a Zometa treatment, and then I had another treatment in 6 months, and I had good results from that. And so my doctor pushed it out to 1 year because it does have that half-life, a lot of effectiveness in your system. So I'm 2 months away from follow-up. So anyway, my question is, I do need some dental work, missing a tooth, a molar in the back. I really got paranoid about osteonecrosis of the jaw and just backed away from any kind of implant or anything. Because I'm so early and I haven't progressed from smoldering, I know there's a lot more you'd probably need to know, but should I be concerned, or is it something that under such little Zometa treatment I could probably get done?
I'm going to leave this to Dr. Raje.
Yeah, no, this is again a good question. And, most times when we've seen problems like the stress fractures and ONJ, it is in the context of increased doses of these drugs and prolonged use of these drugs. Having said that, I think 1 or 2 doses shouldn't matter. And your doctor is treating you exactly how we would consider treating you. He's almost treating you as if you had osteoporosis. And the dose for osteoporosis is once a year of these drugs. If you are getting dental treatment, as long as you are as further away from your Zometa infusion, that's probably the best time to get things done. And even after you do your procedure, stay away from the drugs for a little bit before you get yourself another infusion. But I think doing a yearly infusion is probably perfectly reasonable, and finding the right time to do whatever dental procedure you want to. There's always the outside risk, but it's certainly much, much lower than a person who's getting these drugs once a month, every month for a long time.
Okay, go ahead.
Yeah, I was just going to say I agree 100%. And even for our patients that receive routine treatment, maybe their teeth will fall out or they really need a tooth removed, we'll try to wait about 3 months or 6 months, and there's no good effective data. There was a few papers about antibiotic use around dental extractions. The Italian Myeloma group had a paper out there. And so in some cases, because we know this starts as an infection sometimes, we would recommend antibiotics. Dr. Raje, do you ever recommend antibiotics for your patients who are in active treatment and absolutely need to have a tooth pulled?
So it depends. If doing an antibiotic prophylaxis is perfectly reasonable. Tooth pulling we try and avoid as much as possible. If we need it, we obviously do it, and we try and do it as far out from the infusion. Things like root canals, cleaning should be perfectly reasonable to do. There should not be any problem with any of those.
Okay. But in your case, I think you're safe to just, because it's less often and few doses, it's probably generally safe to not worry too much about it. But discuss that with your oral surgeon and your healthcare team. So
thank you for asking. Yeah, thank you.
Great. I think we're good then. Anything else, Robin?
Okay, I think we are at about the 1 hour point, and so I really like to thank both Drs. Raje and Dr. Faiman, and especially to all of those on tonight's call. We hope this was very helpful to you. And again, thank you to this call's sponsors, Amgen Oncology, Celgene, and Takeda Oncology. And now we'll conclude the call with a quick but very important survey. So if you can please stay on for that, we would very much appreciate it.